the whole nutshell of how things go, of how these three things are linked. It could be a big slide, but if you try and understand any disorder, what will happen to the blood test can be easily discerned from this. As I said, if you start with a primary thing of reduced plasma concentration of calcium, let's start as that. What is the effect? The parathormone secretion will increase. The parathyroid hormone in the level in blood level will increase. What it will do to the kidney? It will reduce the reabsorption of phosphate from the kidney. It will also cause bone resorption, and it will also cause increased formation of 125. All these three things will restore the calcium back to normal. If you start as high calcium, the exact reverse formation will occur. The PTH will be suppressed, 125 will be suppressed, renal excretion will be changed, bone resorption will change, and so on. So, it all depends on what is the starting point. If you look at the basic lab tests, serum calcium per se is a highly misused test. Again, a lot of patients come to doctors with weird symptoms, and doctor tells them, I think tumsa calcium kami zalay, you check your calcium. The point that I am trying to make is, if you estimate serum calcium, first of all, serum calcium is a very difficult test to do. Even if you do it, your serum calcium is not expected to be abnormal in 99% of the situations, because if your bones are adequate, then your calcium levels will not change unless there is something catastrophic happening inside the body. Because as I said, the moment calcium goes down by a small margin, PTH kicks in, 125 kicks in, renal excretion shuts down, bone resorption occurs, intestinal absorption increases, and everything is restored back to normal. So, to find an abnormal calcium is extremely rare, number one. What we find in small labs is rubbish. So, it can be thrown away completely, and treating on the basis of that is even more dangerous. So, forget about that completely. So, calcium level per se does not tell us much unless it is really high or really low, which as I said is unusual. I have oft reiterated that it has to be combined with vitamin D and PTH. The lab where you are testing is very, very important. Calcium is preferably done in a fasting state, and so is phosphate, particularly the phosphate. As I said, correct for albumin, especially in situations where albumin is expected to be low, like chronic liver disease, nephrotic syndrome, acute critical illnesses, etc. What about PTH testing? PTH is underutilized. We use so much of vitamin D testing, but PTH is not so easily done because PTH is difficult to interpret. Somebody assumes that calcium low to PTH low hona chahiye, and then suddenly they find a high PTH, then they say something is wrong, so you forget about PTH. Next time we will not check PTH. I mean, rather than understand why the PTH is high, they don't want to test it. But whatever it is, PTH again can be assayed at different methods. Now, of course, the current assays are what are called intact PTH, that means they assay the whole molecule. But previously, we used to have what is called the carboxy terminal PTH assays and the N terminal PTH assays, and especially in renal failures, we had a big problem in interpreting PTH values. So, that is taken away now. PTH still needs to be done by a very dedicated testing, lot of quality control is required, and this cold chain thing is extraordinarily relevant for PTH. I almost wager you that if you look at PTH values coming from peripheral towns, invariably you will have reports of less than 2, because it is all been degraded by storing at room temperature and then transferring it to Mumbai or wherever they send it. So, you can't do it at all, and these PTH values have no meaning whatsoever. Again, most high values, when you see a high value of PTH, most high values are not because of primary hyperparathyroidism and parathyroid adenoma, but most high values are secondary to vitamin D deficiency. So, that is the most important learning point, that if you do a PTH and if it is high, the chances that 95% of the times or even more, you are dealing with vitamin D deficiency rather than a primary hyperparathyroidism. Again, if you don't know this, then you are directly going to jump to nuclear testing, CT scans, etc., etc., etc. So, if the calcium is normal and the PTH is high, the next thing to test is vitamin D, and if your vitamin D is low, you are dealing with a secondary hyperparathyroidism and not a primary hyperparathyroidism. Vitamin D testing we have talked about, and I am not going to go about it, but there are a couple of other things which I would like to focus upon. And one is again a test which is not often used, which should be used particularly in people who are taking calcium replacements for a long time. See, very often the people will come and ask you that I have got a history of stones, or somebody in my family has a history of stones, should I take calcium or not? The answer to that is that a very small percentage of patients are what are called hypercalciuric. So, they overabsorb calcium and they excrete calcium through the kidneys in a large manner, and they may be susceptible to stone disease. One of the best tests to do here, especially on long term calcium replacements, is to do a urinary calcium creatinine ratio and see if it is normal. If you find that there is hypercalciuria, you need to relook at your policy. So, creatinine levels, because kidney disease is one of the most abnormal factors in calcium metabolism. Serum albumin I have already elaborated, and the urinary calcium excretion apart from calcium, phosphorus, vitamin D, PTH. So, this actually forms the entire test panel. You cannot ask for vitamin D alone, you cannot ask for serum PTH alone, you cannot ask for serum calcium alone. Forget it, it is rubbish and you can't do anything with it. So, that is how it is. What happens when you find hypocalcemia? I am now talking of true hypocalcemia, where you have taken away all these other binding things, corrected it for albumin, etc. The presentation is often like tetany, and very often when your technician is collecting the blood, he will tell you that the patient is getting a spasm. That is a typical carpal spasm, and of course, patients may also present with seizure disorders, mental change, progressive dullness, dementia like state, early age cataracts, and here the commonest cause is hypoparathyroidism. The commonest cause of a serious hypocalcemia is hypoparathyroidism, followed of course by severe malabsorption syndromes, very severe deficiencies of vitamin D, GI surgeries. You will see these people now, because a lot of people getting bariatric surgeries and other surgeries, chronic liver and renal disease, and very importantly anticonvulsant drugs. So, anticonvulsants are notorious because they not only change thyroid metabolism, they also change vitamin D metabolism. They make vitamin D ineffective and they prevent calcium absorption. So, you are very likely to have severe hypocalcemias. So, these are the main things which we look at, and then between them how to differentiate